Hi Neeta. Hi Tejasvi.
Hi, Akshata.
Okay. I just wanted to confirm I'm audible. Okay.
Shall I share my slides once and see whether it
Yes.
fits?
Yes. Hi Teja. How are you?
Hi, hi. Am I audible? I'm fine,
Yes.
I'm fine.
Yes.
I have
Am
sent.
I audible?
Yes. Yes.
Yeah, I have sent request for sharing. I think. Shall I?
I have allowed. You share again. Huh?
Okay.
You try again now. Okay.
Is it visible? And
Yes. Visible.
is it
Yeah.
moving, right?
Yes. Yeah.
Yeah. Okay. Okay. It's what's the time? It's wait for 5 more minutes, right?
Akshata, are my slides visible?
No. Please share. Share now. Na. Share now.
Oh, okay. It's not allowing me to share. 1 minute.
Huh. Yeah. Yeah. It's coming now.
It's coming now, right? Now my slides are visible.
No. You have not shared that screen. You stop share and reshare.
Okay.
Uh, you can share the window only.
Okay. Should I share like window?
Yeah, yeah, share window only. If you're not
Okay.
able to share the screen, particular screen, but close others when it's, yeah. Now you can
Now,
open.
now
Open
are
your
my
PPT. Open your
huh?
PPT now.
Okay. Now is it visible?
No,
Ma'am
it is
is
a
not
white.
joined, I think. Ma'am.
No,
Huh,
I think she may join little late. That
I am not
Okay.
able.
She knows, right? This
yeah,
link.
yeah, yeah. She knows the link. She had joined in between around 4 o'clock.
Okay.
I think. Mhm. After two talks, I will call her once if at all if she has not
Okay.
joined. Teja, you want me to share? I can also share. You have shared the slides, no? But you try once more.
Yes, yes,
Let's
yes.
see.
I'm trying. Wait, it's not allowing me to share.
Are you on a tab? Huh? That
No, on laptop.
laptop only. Then
Hmm. Yes, yes. But I don't know why it's not allowing me to share. Is my screen visible now at least?
no, it is. I think you are sharing it, but some like privacy setting is preventing it. It's like white screen now. That's all.
Okay. Hmm. Why it's not sharing actually? Now?
Yes. You can put it in
Oh,
slideshow now.
okay.
Huh.
You have my slides, right?
Yes.
If it is not
Yes.
sharing, you can share it from your
Yeah.
side.
Yeah. I have the slides.
Thank you.
We'll wait for another 4 to 5 minutes and then we'll start. We'll start. I'm audible, right?
Yeah, you are.
Okay. So, hi everyone. I'm Dr. Akshatha and I welcome you all to the today's special CME titled the NTM 101, a primer for clinicians. It is held on the occasion of World Non-Tuberculosis Mycobacterium Awareness Day, that is today, August 4th. So we spotlight a group of infection that often fly under the radar, that is the non-tuberculous mycobacterial infection. Through this session, we aim to improve the recognition, diagnosis, and management of NTM in the real world setting. So without any further ado, we'll start with it. So we have 5 talks today, that is approach to NTM infection, NTM real case, real challenge, NTM epidemiology, a study from India, lab diagnosis and drug testing in NTM, and is it always NTM? So for those who have joined for the first time, so this is a part of welcome back to my YouTube channel, that is Learn with Dr. Akshatha, where it's a platform where I bring towards case-based learning in infectious diseases. So if you have not subscribed, you can always feel free to subscribe to my channel. So we'll start with first topic, approach to NTM infections. So what are actually these NTMs? NTMs are not either. So we have something called MTB complex, that is your tuberculosis and leprae. So these are NTM is also known as environmental mycobacteria, opportunistic mycobacteria, atypical mycobacteria or MOT, that is mycobacteria other than tuberculosis. The typical characteristic of NTM is it is found in the environment. It's opportunistic pathogen in humans, and there are more than 172 species. And why are the NTM infections increasing? So we have greater exposure, that is greater exposure to aerosols, invasive procedures, changing plumbing practices, and there is now improved diagnostics. That is, we have more sensitive culture methods which is available, more CT scans which have been done, and the host factors, that is aging population, so and more patients with lung diseases, more immunosuppressed patients, and with the decrease in tuberculosis, NTM are going to increase. That is what it is seen in other countries. And there is also some studies which are showing that the NTMs are becoming more and more virulent. NTM lung disease especially is underestimated in country like India, where we have a lot of TB which is there, and also it is because of the increased disease awareness. So I'm sure many of you will be familiar with this table. So the NTM is classified typically into rapid growers and slow growers. The rapid growers which grow within 7 days, and slow growers which grows more than which take more time to grow. In the slow growers, we have photochromogens, cotochromogen, and non-chromogenic. Photochromogens includes Mycobacterium cancerci, marinum, cotochromogen even includes your scrofulaceum, and non-chromogens your MAC complex, Mycobacterium chimera, ulcerans, xenopi, etc. The rapid growers include your Mycobacterium abscessus complex, which includes subspecies abscessus, boleti, mesilensi, and fortutum and cheloni. So it is necessary that you know these names, because the treatment you're going to decide is based on the different type, whether it's a rapid grower, whether it's a slow grower, and what species it is. So this difference, I am sure most of you will be familiar with it. So what makes NTM distinct from the TB? First and foremost is TB is always pathogenic, and it's an obligate pathogen. Does not it requires host. It is always pathogenic, and the human to human transmission, as you all know, is definitely there. And whereas NTM is not obligate pathogens, they are found easily in the environment. It is generally low virulence and not always pathogenic. Human to human transmission is rare, but nowadays there is increased risk, especially cystic fibrosis community. Infection rates is increasing as in NTM, especially in the developed countries. So this is how it differs like in the microscope. Under the microscope, you can see this the right side represents the TB, where you see the serpentine cord-like rope-like aggregates, which are both of them are acid fast, and whereas NTM will lack these serpentine cords. Even treatment-wise, NTM and TB is distinct from the duration of therapy, the resistance we see because of the long. So NTM needs to be treated for longer. Multiple combination therapy should be given. So it is associated with a lot more toxicity, and there are lot more relapses which is seen, and we do have many more species which we need to taper the. We need to titrate the treatment accordingly. And it is found throughout the environment, from natural water sources, hot tubs to hospital instruments. So the transmission of NTM can be multifaceted, or it can be inhalational, ingestion, contamination of hospital water supplies. Person to person is extremely rare, but as I mentioned, in cystic fibrosis community, Mycobacterium abscessus has been, in some studies have shown person to person transmission. GERD is also one of the risk factors. It's like has been indicated as a mediator of NTM lung disease, because patients swallow the NTM, and then due to the GERD, it can lead to aspiration into the lung. So these are the various sources of the NTM. Based on the source as well, the commonly isolated NTM can vary. The risk factors, these are the typical risk factors for the NTM. Your environment, lung, that is structural lung disease, any cosmetic procedures including tattooing, surgery, and immunodeficiency, especially the CFTR mutations. So this is a table representing the risk factors for pulmonary disease versus the risk factor for extrapulmonary. As you can see, for the risk factors for the extrapulmonary in general involves mostly cosmetic surgery, any device related like prosthetic device, implants, organ transplantation, injections, joint injections, invasive procedures like pacemakers. While pulmonary NTM, as I mentioned, any destroyed lung, so previous history of TB, bronchiectasis, COPD, uh, mutations like CFTR causing cystic fibrosis. So any structural lung disease, lung cancer, etc. So major manifestations of NTM includes four, that is a pulmonary disease, lymphatic disease, and disseminated disease, skin and soft tissue, which includes your bone and joint. So common species again will vary depending upon the site of infection. Pulmonary in general, it is mostly MAC, followed and it's not in any particular order because the epidemiology varies from place to place. In general, it is pulmonary MAC, Cancer C, Xenopy, abscessus, fortuitum. In the skin, we have Mycobacterium ulcerans, marinum, abscessus, chyloni, fortuitums. Lymphadenitis is in general by MAC and scrofulatium. Disseminated in general is by MAC, especially seen in the HIV patients. And not all the isolation of NTM is equal. So there are some species which are usually are colonizer and some species which may always be pathogenic. So certain species like Gordoni, especially is generally associated with contamination or colonization rather than the actual infection. But isolation of MAC, that is Mycobacterium avium complex or abscessus, is in general pathogenic. So when to look for lung disease in a patient? NTM lung disease. So, patient having persistent cough, hemoptysis, weight loss, rapid worsening even on standard therapy, and characteristic radiological picture. That is when you will suspect NTM. So, it is just like TB. So, whenever you're thinking of TB and the patient may not come back with a mycobacterial test with the TB positive report, you need to consider NTM as well. So in that case, you need to, especially when the patient is having a structural lung disease, you need to consider the NTM. You need to send sputum culture, three sequential sputum cultures should be done or BAL. And all the patients who is having bronchiectasis should be tested. The sputum should be tested for NTM. So when to suspect extrapulmonary NTM? So whenever a patient is having any infection which is non-resolving with multiple antibiotic trials, the risk factors which I mentioned previously for the extrapulmonary NTM, any non-healing ulcer, chronic discharging sinus, post-surgical sites, any device in situ. So that is when you should think of NTM. And especially if you send the culture and you're seeing AFB positive but gene expert negative, or culture growing NTM from sterile sites, or in histopathology report showing chronic granulomatous inflammation without TB confirmation. That is when you'll think of NTM. Like for example, non-healing skin and soft tissue lesions like post-traumatic or post-surgical wounds after cosmetic procedure like tattooing, nodules, abscess, lymphadenitis, especially in children, which is commonly due to MAC and scrofulatium. Disseminated disease, you will think when patient is typically severely immunocompromised like HIV, transplant, and if the patient is having any device in situ like coronary stent or a pacemaker, you will think of even NTM associated infective endocarditis as well. And even in genitourinary infertility workups or salpingitis in especially TB endemic country, if it is coming positive, you should consider NTM as well. Bone and joint infection you will consider when the patient is having chronic osteomyelitis, which is not responding to usual antibiotics, especially if the patient has undergone has a prostatitis or has underwent some multiple injections or had a trauma. Surgical site related infection, as I mentioned, any device, especially catheters, pacemakers, and typically, Mycobacterium chimera is associated with the use of heater cooler units in heart cardiac surgeries. So this I'm sure further speakers will be elaborating on. So these are the recommended microbiological tests which will help in diagnosis of NTM, which includes microscopy, your cultures, and the various molecular tests which is currently available for the speciation, including LPA, MALDI-TOF sequencing, whole genome sequencing, and we also have certain NATs, that is nucleic acid amplification techniques, like your CBNAT for the NTM as well. So, what is the diagnostic criteria for NTM lung disease? We basically have three criteria: the radiological criteria, microbiological criteria, and the clinical criteria. So, radiological criteria is presence of any nodular or cavitary structures or multifocal bronchiectasis with the exclusion of other causes. That is very important. Then we have the microbiological criteria where two, so if you have sent three sample, at least two positive sputum culture, or if you have sent a bile sample, one positive bronchoalveolar lavage culture which is showing NTM, or transbronchial or other lung biopsy which is demonstrating the same. Clinical criteria is patient having bronchopulmonary symptoms and with the exclusion of other lung disease. So in general, this is the principle. You should have a radiological criteria, microbiological criteria, clinical criteria for the lung disease. For extrapulmonary, you may not have the radiological criteria, but repeated culture. If it is a sterile site, one specimen is sufficient. If it is a non-sterile site, multiple isolation of the NTM. So the diagnosis, as I mentioned briefly. So we will try to learn more about it through cases. So we have a case. A 66-year-old female ex-smoker with a BMI of 19 with history of hypertension, PVD, GERD, rhinitis, presented with two-year history of breathlessness and dry cough. She can walk fine on flat surfaces, but struggles when there is inclination. Chest X-ray is normal, but spirometry shows moderate obstruction. She has been treated as COPD with no improvement with bronchodilators or steroid. Cardiac workup is normal. She presents after 3 years with worsening cough and is homebound. So this was the initial X-ray, chest X-ray, which almost showed normal. The CT is showing bronchiolitis, bronchiectasis with upper lobe predominance. So this is what is the in general situation in any patient. So these patients will experience multiple pulmonary symptoms like cough, breathlessness. He visits the physician. These symptoms may be misdiagnosed as asthma, bronchitis, COPD, or even treated for tuberculosis. But the patient will have some improvement, but obviously it's not treated for the cause, so the symptoms will persist or worsen, and then he will be coming to the finally maybe expert who will do the diagnosis of NTM and start the treatment. So during this process, a delay of almost 2 years or more is there. So at last, in this patient culture, serial cultures were sent, which group MAC. So we confirmed it is NTM, pulmonary disease or lung disease, and uh, we need to initiate the treatment. So where do we look at the guidelines for? So there are various guidances rather than guidance which is available for the treatment. Most commonly we use the BTS, that is British Thoracic Society, or the American Thoracic Society, ERS, ECMED, IDSA criteria. That is ATS, ERS, ECMED, IDSA is a recent one. So first and foremost, you need to find out whether is the disease positive by sputum culture, and the species, is it pathogenic, and what type of the disease is it? Is it cavitatory, nodular, or bronchiectatic? So in our patient, the patient had MAC, that is Mycobacterium intracellular, is a subspecies of Mycobacterium is a species of Mycobacterium avium complex. So what are the drugs? So ideally, for all the treatment of the NTM, you need to identify the species, and based on this, after the speciation, you need to get the antimicrobial susceptibility. So for MAC, we need to test macrolide and amikacin. Rifampicin and ethambutol MICs are not shown to be clinically relevant. So these two are the things you need to test for. So then, depending upon the type of disease, whether it is nodular, bronchiectatic, cavitatory, or refractory, you will decide the treatment. If it is just mild disease, nodular and bronchiectatic, 3 drugs is sufficient, which you can give 3 times weekly. So the base for MAC is macrolide, rifampicin, ethambutol. So macrolide can be azithromycin or clarithromycin, rifampicin or rifabutin. So in case of cavitatory disease, we need to give initial therapy, which can be you can include IV, or you can give, if the patient is not very severe, you can give 3 drug therapy, which includes your macrolide, rifampicin, ethambutol, which is given daily instead of 3 times weekly. And in case of refractory cases, where refractory in the sense the patient's having symptoms or persistent culture positive, then we may have to give a injectable, that is amikacin IV, or amikacin liposome inhalation suspension also can be tried. And the duration of treatment in general for NTM is 12 months beyond the culture conversion, not your gram stain, AFB stain. It is a culture conversion. So this patient was started on azithromycin, ethambutol, rifampicin thrice weekly with physiotherapy. She had GERD, which was managed concurrently. Cultures were negative at 2 months. So she had some adverse effects like nausea, diarrhea, appetite loss. Other important thing you need to consider in NTM is always look for the drug interaction, and rifampicin was discontinued, and the patient themselves stopped all the medication at the end of 9 months. So what are the challenges in diagnosing NTM lung disease? One is a non-specific presentation. So they will present with shortness of breath or breathlessness and dry cough. So misdiagnosed. Normal chest, initial chest x-rays, missed early opportunities because cultures may not have been performed, and multiple times they may be treated as exacerbation of the COPD. Delayed diagnosis. The median delay in diagnosing NTM lung disease is as much as 2 years. So we need to get a CT chest and full lung function evaluation. So what were the things which was missed in this patient if you look back? So there were multiple risk factors for the NTM lung disease in this patient. The female sex is one of the thing, because there is something called Lady Windermere effect. So especially NTM is more common in patients who suppress cough. So Lady Windermere was like previously that was a custom that women cannot cough out loudly. So that is one of the risk factor. Low BMI, GERD, COPD, which was maybe misdiagnosed, bronchiectasis. Next, she had persistent symptoms, and there was also use of inhaled corticosteroids, which may have worsened the NTM disease. Moving on to the next case, a known COPD and GRD is referred for worsening respiratory symptoms. Before, he was also treated for 12 months for this NTM lung disease. When he had presented with 6-month history of weight loss, cough, occasional fever, initial sputum grew MAC and Haemophilus influenza. So he was treated with amoxiclav, with which the H influenza was cleared. And he was also started on azithromycin, rifampicin, ethambutol, that is the standard for MAC. After 1 year, 12 months, his symptoms worsened. There was large cavitatory lesion, and the culture was positive for MAC. So what went wrong here? When you look back at the history, when you take the history, the patient had been taking long-term azithromycin as prophylaxis for his COPD. So, and also if you say there was no susceptibility test which was performed. So what should have been done? Ideally, resistance testing should be done, especially macrolide resistance in MAC is known. So especially if the patient has been exposed to macrolides before. So he was initiated now on IV amikacin followed by nebulized amikacin. Orally, rifampicin, ethambutol, linezolid, clofazimine was given. And especially when there is such a large cavitatory lesion, there can, and if the patient is relapsing, surgical treatment also should be considered. But again, most of the patients or the CTVs may not be willing for the surgery. Finally, he achieved culture conversion after 6 months. So, what are the critical learning from this case? Pre-treatment resistance is, testing is essential. Long-term macrolide use may promote resistance in NTM if it is undiagnosed, and we need to screen for NTM before starting any chronic macrolide therapy in a patient, especially with multiple exacerbation of COPD. It's a common practice. We need to screen for NTM in such case. And is it final that like you have diagnosed, you have started the antibiotic? Is it the end of the case? No. You need to address certain things in especially NTM because more than just that giving antibiotics, there are a lot of things which you need to consider. You need to evaluate for and address the predisposing condition. If the patient has structural lung disease, if he has GERD, you should correct that. And the mutations, or if there is any immunocompromising condition, that should be addressed. Management of underlying bronchiectasis and co-infections, including airway clearance, judicious antimicrobial therapy of, so there can be co-infections, like even there can be aspergillus as co-infection. So you need to consider that as well. You need to monitor for the progression at periodically, including sputum samples, repeat sputum cultures, imaging, pulmonary function tests, and if it is environmentally acquired, you need to minimize the exposure to the further source. So patient factor, radiological factor, and microbiological factor should be considered. And pharmacological, as much as pharmacological treatment is important, including antimicrobial, anti-inflammatory, and symptom treatment, non-pharmacological treatment is also important. You need to educate the patient. You need to teach airway clearance. You need to do the airway clearance therapy, exercise training, inspiratory muscle training, nutrition, and psychological support because they are going to be on the treatment for very long. And just like endocarditis team, it is necessary that you have a multidisciplinary NTM team, which consists of your pulmonologist, ID specialist, clinical pharmacists, surgeons, respiratory therapists, nurses, social workers, patient support groups, clinical microbiologists, and pathologists. So it is just like an endocarditis. NTM also requires multidisciplinary management. Next, we move on to the next case. A patient with a 79-year female with complicated urological history with multiple history of urinary tract infection requiring urinary catheter for several months. She has been treated multiple times with cotrimoxazole with no symptomatic relief. So now what has happened? The patient, the CT imaging is showing thickened bladder wall consistent with cystitis and has persistent symptoms, pyuria and urine cultures. Urine cultures multiple, bacterial was negative. Now it is growing candida. She was started on antifungal for the candida cystitis. So the patient has basically sterile pyuria. So you need to always consider even TB or NTM in patient presenting with multiple the recurrent UTI with sterile pyuria. So you need to send for cultures for AFB. So it was AFB positive and culture group Mycobacterium abscessus. So what are the critical learning from this case? You should not ignore sterile pyuria. It may indicate TB or NTM, especially if there is persistent symptoms. You must consider NTM in chronic UTI symptoms which are non-responsive to the standard treatment. AFB urine culture should be sent early in chronic sterile pyuria, and we need to evaluate comprehensively, including biopsy, early imaging, AFB in such cases. Mycobacterium abscesses, again, it's a very complicated NTM. It's one of the complicated NTMs with very important because of the resistance, that is a macrolide resistance. So they have two types of resistance, mutational and inducible. Mutational will confer high level resistance, inducible. It is most commonly in abscesses. So as I mentioned, abscesses, Mycobacterium abscesses, subspecies abscesses, Messelensi and Boleti. Messelensi does not have much of inducible resistance, whereas the others will have. So how will you identify? So this, I am sure we'll be learning about this in uh, further talks. So you need to identify whether the patient is having inducible resistance to the macrolide therapy or no. If it is inducible, then you cannot use, you will use macrolide in therapy, but it is only for the anti-inflammatory properties of the macrolide, that is your azithromycin or clarithromycin, rather than the antibacterial purpose. So when the treatment of Mycobacterium abscesses is in general has two phases. The initial phase you will consider if there is no inducible AMC, then you consider at least 3 drugs, 3 to 4, depending upon the severity of the infection. So, which includes injection parenteral, at least 2 drugs parenteral out of either you can choose amikacin, imipenem, TG-cycline, etc. Oral with 2 oral drugs, that is your macrolide, azithromycin, which will always be a component irrespective of resistance. But if it is because of, if there is resistance to the macrolide, you are not going to count this drug as a part of the 4 drugs, 4 active drugs. Okay, so oral, it can be azithromycin, clofazimine, linezolid, tedizolid, bedaquiline, etc. So after the initial phase, you can, after 2 to 4 months, 2 to 3 months or 2 to 4 months, depending upon the culture conversion, you can continue with the continue to the continuation phase, where you can choose two to 3 drugs depending upon the type of infection. So these are the other available therapy for Mycobacterium abscesses, that is omadacycline, tedizolid, dual beta-lactams. Even fast therapy has been tried. So next I have a case. So this is a very common presentation of NTM, I can say. So a 20-year-old female with no comorbidities came with history of pus discharge from LSCS site, which was operated, which was done 4 months ago. There was a lump felt, there was a sinus present beneath the scar of the LSCS. At this point, there was no active discharge. USG abdomen showed sinus tract, and the pus aspirate showed no growth and expert negative. I am sure you will all be familiar with the situation where sometimes you may not be able to even isolate the, like even AFB may be negative. Now you're in a dilemma whether it is SSI due to unusual organism like including NTM, or it is just chronic bacterial infection, tuberculous sinus, or surgical granuloma, or foreign body reaction, or deep-seated abscess. So how do we proceed? So the sinus, whenever there is a sinus, even if it is NTM, ideally you have to do the surgical sinus excision or debridement. And this will also be helpful in case it is just stitched sinus or foreign body. If it is NTM or TB confirmed, initiate. If no organism, only chronic inflammation is present, you can always consider the surgical excision. So do you need to give empiric ATT in this patient? So empirical antibiotics, that is ATT, should be deferred until proper cultures are taken. If AFB positive, expert is negative, NTM is likely, but not always. So what empiric? So if you are seeing that it has culture, AFB is positive, but expert is negative, what empiric ATT you are going to start? It depends on the site of infection. Here it is a skin and soft tissue, where commonly we see Mycobacterium abscesses, fortuitum. And again, that's why it is important, even if your lab is not able to speciate, at least you should know in your country or in your area which NTMs are common. Then I use at least 2 to 3 active drugs to avoid resistance and give the treatment for minimum 3 to 6 months depending upon the response. So what drugs? So you can use either clarithromycin, amikacin or imipenem for the initiation phase, followed by oral conversion. You can use clarithrolinazoline or clarithroclofazamine. So stepwise approach to empiric therapy. I'm sure like there is various guidelines which you, if you want, if you have identified the species and you have the susceptibility, your treatment of the NTM is going to be based on that. Sometimes, especially in scenario like India, most of the times we may not have the species. Even if you have the species, you may not have the susceptibility. So just last two slides on that. So what are you going to do? For the empiric therapy, first is look at the clinical symptoms. Is it typical for your NTM? Imaging findings. Is AFB smear positive, gene expert negative? That is when you will think of NTM. Assess the disease severity, whether it is severe or non-severe, because you will be changing the duration of the initial phase and the continuation phase based on that. Then, based on the site of infection, you should which species is more likely. Especially, you need to differentiate whether it is your slow grower or rapid growers. Rapid growers, commonly it is your abscesses, your fortuitum. So because the treatment or the empiric treatment you're going to add or the drugs you're going to choose depends on that. Check history of prior antibiotic use. Was there any use of macrolide monotherapy? Was there any immunosuppressant present or use previously ATT has been given? Start empiric therapy. If severe disease, high degrade suspicion with pending cultures with AFB positive smear. So what empiric therapy in general? Some pulmonary MAC non-severe, you can consider your MAC therapy, especially pulmonary in severe diseases, MAC plus IV amikacin. In suspected rapid growers like abscesses, so especially skin and soft tissue infection. Sometimes in some areas, lung infection, abscesses is again more common. And in transplant setting, if the patient is having any lung disease which you are suspecting NTM, again, you need to cover for abscesses. In such a situation, you can give IV amikacin plus imipenem plus macrolide with or without clofazamine or linezolid. And always follow the cultures which you have sent and reassess once the culture is there whether you have the ID, you have the susceptibility, and modify the empiric therapy accordingly. Sometimes you have the situation, you have the NTM species, so but your facility or your hospital does not have the facility to do the antimicrobial susceptibility. Then how are you going to decide the regimen? So this is an excellent table which I've taken from an Italian guidelines for non-tubercular management or treatment of non-tuberculous mycobacteria. So here we have the green represents the active drug. So for Cancer C, for example, Mycobacterium cancer C, it is just Cancer C is just like TB. So mostly you will need rifampicin, isoniazid, ethambutol, and with a macrolide azithromycin. So three drugs you should use, which must include your isoniazid, rifampicin, and your macrolide. Similarly, for other species, you can look into this table, and if you want to create a regimen, if you're not having an antimicrobial susceptibility for the NTM, you can refer this. There are various tables which are available, but in Indian scenario, I feel most of the time we either have the species or we don't have the species as well. So I'm sure you will find these tables anywhere. So the duration of therapy is next thing. It is in general for lung disease 12 months after the culture becomes negative. Pulmonary disseminated, it is 12 months after the culture negative. For lymphadenitis, ideally it is just surgical management. If Especially in children, and in skin and soft tissue infection, it is 4 to 6 months. Osteomyelitis, again 12 months after the surgical management or the cultures. So just summarizing, MAC, it is the treatment of choice is azithromycin, rifampicin, ethambutol. Cancer C, it is isoniazid, rifampicin plus ethambutol plus or minus your azithromycin. Abscesses, look for macrolide resistance and you will use combination of 4 followed by 3 drugs. In Mycobacterium abscess, MAC infection, prophylaxis is not routinely indicated, but in patients who are RVD positive, RVD, you need to put them on prophylaxis with azithromycin weekly only if they are not started on ATT. Duration, in general, it is 12 months after the negative culture. So that's my final slide. So NTM and TB should be differentiated and at least send 3 sequential sample if NTM is suspected. Species identification is a must because treatment varies depending on the species. Especially macrolide susceptibility is required in abscesses. Suspect NTM in all patients who are on ATT but not responding and who are multiple times AFB positive and expert negative. And in general, MAC prophylaxis is not required for all the patients. So these were my references. Thank you. I'll stop sharing the screen now. We can take the questions. Okay, I'm muted. Let's see if there are any questions. Okay, we'll take the questions in the end. So next we have Dr. Vasireddy Teja. Can you share the screen? Yeah. Next we have Dr. Vasireddy Teja. She is Chief Infectious Disease Consultant at Medigo Hospitals, Tirupati. Over to you, Dr. Teja.
Are my slides visible?
No, it was there. Now it's visible. Can you put it on slideshow, please? Yeah.
It's okay, right?
Yes.
So we'll start with the case. It's a 42-year female patient. She's hailing from Tirupati, Andhra Pradesh. She came with chief complaint of fever since 15 days and cough since 10 days. The fever was insidious onset, intermittent, which was low grade, associated with evening raise of temperature and not associated with any chills or rigors. And the fever was associated with nausea. The cough was also insidious onset, productive with yellowish sputum. Initially, it was non-blood stain, moderate in amount, non-foul smelling, associated with shortness of breath, grade 2, which was not associated with any chest pain, wheeze, or palpitations. So she has a very long past history, so carefully follow her. In 1991, she underwent road traffic accident for which she had laryngeal stenosis. So she had status post laryngeal reconstruction in 1991 at CMC Vellore. In 2013, she was diagnosed at an outside hospital in Tirupati with clinical diagnosis of pulmonary TB. There was no culture or there was no CBNet. She was initiated on ATD in the 2013, which she has taken for 6 months. So again in 2022, she was told she had pulmonary TB and ATT was given in a outside hospital at Tirupati. Then she went to CMC Vellore because she had a CVA. So the CVA was treated and she has returned, but she had recurrent CVA in the next month. So she had 2 episodes of CVA, which were treated at CMC Vellore, and she had same symptoms of respiratory symptoms. So she visited Apollo Chennai. Their CBNet was done, which was also negative, but they have started her on ATD. TB culture was not done at Apollo Chennai too. So the BAL, she has multiple episodes of bronchoscopy was not done in the initial stage because she had laryngeal reconstruction. Even the Apollo Chennai and CMC couldn't do the bronchoscopy. So she finally went to Yashoda Hospital in May 2023, where coablator assisted supraglottoplasty was done only to facilitate bronchoscopy. So that is the only bronchoscopy she underwent. So on general examination, patient is conscious, coherent, and cooperative. There was no paler icterus cyanosis, clubbing, or edema. There was a scar present over the anterior neck area because of the past history of laryngeal reconstruction. On respiratory examination, you could see right suprascapular area bronchial breath sounds were heard, and bilateral infrascapular area coarse crepitations were present. The remaining systemic examination was normal. So the investigations, the CBC, LFT, and RFT were normal. So this is the radiology. You could see the right upper lobe. You could see there is collapse along with the right lower lobe and the middle lobe. You could see multiple cavitations with bulle. So this is the past radiology where she had underwent in CMC and Apollo. This is the past sputum analysis of 2022 where the gram stain, AFB, culture, CBNet and MGIT was negative. So this is the bronchoscopy which she underwent at Yashoda Hospital in April 2023. You could see left upper lobe opening appears occluded with white necrotic lesion in the opening, and there is an extrinsic compression. The mucosal area was inflamed and edematous. So BAL was taken. The BAL fluid analysis, you could see gram stain, AFB, fungal stain and culture was negative. The bacterial culture, there was no growth. CBNet was negative. The only MGIT culture she had, mod species grown in the 4th week. The BAL was done in the Yashoda and the sample was also taken to CMC Vellore. So this is the CMC Vellore CECT report. The CECT thorax showed a lung volume loss with cystic bronchectasis changes and cavitation in the right upper lobe. So there was right bronchial artery was noted to be dilated with multiple enlarged conglomerated lymph nodes in right paratracheal and subcarinal region, which was suggestive of active TB infection. She underwent bronchial artery embolization because she had history of recurrent hemoptysis. And bronchoscopy was done with extensive bronchial inflammation in multiple airways. With BAL, MTB expert was negative, and AFB in the CMC Vellore report was positive, AFB smear, that the CBNet was negative. Antiplatelet agents for the CVA, recurrent CVA, were stopped because of the hemoptysis. This is the empirical treatment before the speciation and the sensitivity was done. This was the treatment given at CMC Vellore. She was initiated on amikacin, clarithromycin, ethambutol, moxifloxacin. The remaining were supportive therapy for the patient. So this is the culture and sensitivity which was obtained on May 2023. You could see the species to be a non-tuberculous mycobacteria, which was identified as Mycobacterium intracellulare. So the amikacin was resistant, clarithromycin is susceptible, rifampicin is resistant, cotrimoxazole is resistant, and linezolid is resistant, and moxifloxacin is intermediate. So the treatment history, she has multiple history of ATD to be given because she was diagnosed clinical history of ATD. In May 2023, she had received empirical treatment for NTM. Then afterwards, the CMC Vellore has shifted her treatment to injection amikacin, clarithromycin, ethambutol, and moxifloxacin. She couldn't undergo next culture. The sputum was, the patient was not producing sputum, and bronchoscopy couldn't be done because the patient was not willing. And the first bronchoscopy, she had underwent a surgery for the bronchoscopy, so that she was not willing to undergo second surgery to facilitate bronchoscopy. So CMC Vellore team initiated her on secondary prophylaxis with azithromycin. So now she presented with again similar episodes of fever, shortness of breath, which has increased from grade 2 to grade 4, and she had recurrent hemoptysis episodes now. On respiratory examination, she has right suprascapular area bronchial breath sounds, and bilateral infrascapular area coarse crepitations were present. Now she has, you can see right and left bilateral involvement with bulle and cavitation and bronchectasis. So now the sputum has grown, two to three samples has grown mott with the same Mycobacterium intracellulare complex. The sensitivity to amikacin is now resistant. The cotrimoxazole is resistant. You could see every linezolid is resistant. The only drug to be sensitive here is clarithromycin. So the final diagnosis is multi-drug resistant Mycobacterium intracellular complex infection with multifocal cavitatory consolidation with cystic bronchectasis, with recurrent hemoptysis, status post bronchial artery embolization, with recurrent CVA, with post-traumatic laryngeal stenosis, status post laryngeal reconstruction. She had status post coablation assisted supraglottoplasty to facilitate bronchoscopy, and she is a known case of hypothyroid. So what are the treatment challenges? Because it is a multi-drug resistant, we initiated her on bedaquiline, clofazimine, tigecycline, and clarithromycin. So she was initiated like only 1 week. So, what are the challenges? Because she cannot undergo further bronchoscopy, we cannot see whether cultures could be positive or not. Now she is not even producing the sputum. So we have to see what is the duration of therapy, what is the further bronchoscopy, how to facilitate her for bronchoscopy, and what are the follow-up cultures, how the culture will turn up negative or will be remaining as positive. And the treatment monitoring and progress, because he has multiple comorbidities like CVA, hemoptysis, and hypothyroidism. So we have to see multiple drug-drug interactions and further follow-up of the treatment. So these are the newer NTM drugs. As you could see, phase 1 and phase 2, clofazimine, liposomal amikacin, and nitric oxide are there. Phase 3, we have clarithromycin, azithromycin, and moxifloxacin, and liposomal amikacin for inhalation. And phase 4, we have linezolid. And other trials which are done, they are done for rapid organisms like omadacycline for Mycobacterium abscescens, and recombinant IL-7 agent is there, and nitric oxide is there. So in India, we now have bidaquilin, clofazimine for MDR organisms as a treatment. Bidaquilin and clofazimine are in the treatment options for MDR NTM organisms. So thank you.
Thank you, Dr. Teja. It was, I mean, yes, in NTM, as much as we discussed, there is a lot of new things to learn. And especially when we don't have the guidelines for the treatment, and then when we have faced with resistance, yes, that's another challenge.
There are no guidelines for multi-drug resistant at all for NTM. We have only TB guidelines.
Yes. So thank you, and for use of the bedaquiline again. That's a new thing. So lots to learn. Thank you again for making time and sharing your case and insights here. Next, we move on to the next topic, NTM epidemiology, a study from India. We have Dr. Nikhil John, who is currently a senior resident in PDCC infectious diseases in AIMS Mangalgiri, who will be talking about his study on NTM and in general the epidemiology of NTM. Over to you, Dr. Nikhil.
Hello, good evening. Am I audible?
Yes. Yeah, please share your screen, Nikhil.
I'll just share my screen. Is the screen visible, ma'am?
Yes. Can you put it on slideshow?
Yes. Yes, ma'am. Is it visible?
Yes. Yes, Nikhil, proceed.
So, good evening, all. My short talk will be on NTM's epidemiology and be focusing on my study, which is done at AIMS Jodhpur, and the why and how of NTM epidemiology. We see a lot of NTM cases. We see them in clinical practice. We isolate them in our labs. But where is it coming from? Why is it coming? We look a little closer into that. So, if a good hot shower, there's a good chance that we inhaled in aerosols of NTM, because there are a lot of studies coming up with respect to the biofilm in our shower heads, which shows a lot of isolation of NTM. So that is one fun fact for you to start with. And there are studies where they have performed dehumidification at the end of your shower, where they have seen that there is absence of NTM. So in that humidified environment, when there is NTM on the shower head, there's a good chance that the person taking the shower can be exposed to NTM. And again, as you all know, the main problem with the BCG vaccine and any other TB vaccine which is in the pipeline is the exposure to the NTM and its association with our immune system with respect to development of immunity against Mycobacterium tuberculosis. So that causes pre-existing sensitization, immune tolerance, antigenic cross-reactivity, can cause a lot of other problems with the upcoming vaccine trials as well. So that is why even the candidate vaccine Mycobacterium W indicus pranae had to face a lot of problems. So this the lesser seen problems with NTM epidemiology. Let's go into my where we isolated non-tuberculous mycobacteria from both pulmonary and extrapulmonary samples. The organism was grown on LJ media. We also used liquid culture media in the form of middle. Identification of these organisms were done based on line probe assay and also confirmed using Malditoff. So we used card tests like MPT64 to rule out Mycobacterium tuberculosis. We also did clinical correlation with the help of ATM. Since there is no set criteria isolated, is a pathogen or a colonizer, we had to go through a lot of biochemical tests. We had to go through a lot of clinical data and correlate even if a radiological picture was available. So again, a simple image explaining the principle of reverse hybridization, which is again the principle of line probe assay. So in hybridization, what do you do? Look at this image. Garlic bread is being dipped into cheese. So cheese is your DNA fragment. So your DNA fragments are the base. So your probe is added to your DNA fragments. That is hybridization. Reverse hybridization, the probe is stabilized, and on that your amplicon, your DNA fragments are spread over like cheese. So this becomes your pizza dough with your cheese on it. So moving forward, this is
Still, your voice is breaking.
workflows. You have a suspected case of pulmonary or extrapulmonary NTM disease. Here in this case, you have a patient with bronchiectasis with mucoid plugging surrounding central lobular nodules. Again, with NTM, these are not very specific. They can be present there.
I think we lost Nikhil's network. Just a second. Oh, sorry for the inconvenience. He's rejoining again. In the meanwhile, let's see if there are any questions. Those who are joining us on YouTube, please feel free to put it in the chat, any questions if you have. Dr. Nikhil.
Am I audible now?
Yes.
Am I audible now, ma'am?
You're audible. Share the screen, no?
Yes, ma'am. So, yes.
Yes.
Am I audible again, ma'am?
You're audible. Put it in slideshow.
Yes. Yes. Yeah, so sorry for the hiccup.
Nikhil, your voice is breaking a lot.
You get your
Hello.
pulmonary and extrapulmonary samples. Then you do microscopy. Then you inoculate it on your culture media, liquid media, solid media. Just a minute. Audible now, ma'am? Now? Hello, ma'am. Is it audible now?
And now it is audible, but in between it breaks a lot. So
Just a
yeah,
minute, ma'am.
yeah.
It's better now, no, ma'am?
Yes, it's better now. Please
Okay, ma'am.
continue. Yeah.
Yeah. Sorry for that hiccup. So again, continuing with culture, the example of Mycobacterium got mycobacterial. Excuse me. And Mycobacterium abscesses complex on LJ media. You're able to see MPT64 card test, which is positive for Mycobacterium tuberculosis, negative for non-tuberculous mycobacteria. These are the various band patterns on line probe assay, which you're able to see here. One is the CM kit, which is the common mycobacteria kit, and the other is the AS kit, additional species kit. So in my study, there are around 5,838 samples over 30 months. So around 2,426 were extra pulmonary samples and 3,412 were pulmonary samples. These were all received at the mycobacteriology lab. Around 5 to 6%, 5.5% of it grew Mycobacterium tuberculosis and 3.28% grew NTM. So these are again representative images of that. Out of the 192 samples with growth of NTM, 40 were extra pulmonary and 152 were pulmonary. So totally there were 192 isolates. Out of this 192 isolates, all these isolates belong to 121 patients. The most common presentation was pulmonary disease, followed by disseminated disease. You had cases of pleural effusion, skin and soft tissue infection, few cases of meningoencephalitis, musculoskeletal disease, peritonitis, abdominal lymphadenitis, genitourinary disease, and terminal ileitis. So the most common species isolated was Mycobacterium intracellulae, followed by Mycobacterium abscess. So here to note, in pulmonary samples, the most common sample was Mycobacterium intracellulae, and in extrapulmonary samples, it was Mycobacterium abscessus, following with our Indian epidemiological trend, as well as the global trend in most places. So since we did the clinical correlation with the help of ATS, IDSI criteria, out of the 121 patients, 90 patients were suspected to have pulmonary disease. 70 people fulfilled the criteria, whereas 20 didn't. So among the 121 subjects, 10 patients had HIV, 50 patients had history of smoking. Sorry, 50. Some patients had history of smoking, some patients had history of pulmonary TB, some had history of immunosuppressive drugs or steroids, some had history of invasive procedures. So coming to our end result, so out of 121 subjects, almost 100 patients out of the 121 were diagnosed to be clinically relevant NTM disease. The remaining 21 were set aside as colonizers. So the main thing here is, according to ATS IDSA criteria, if you're sending a sputum sample, multiple samples have to be sent, multiple isolations are required, especially when a less pathogenic or non-pathogenic NTM species is being isolated. Multiple isolations and molecular or Malditov base identification are sought after. So coming to a few epidemiological pearls with NTM disease. So as we saw, Mycobacterium avium complex, which is again Mycobacterium intracellular is a part of it. It's the most prevalent NTM species worldwide. Pulmonary NTM disease is most common clinical manifestation. The incidence of NTM disease is increasing globally, especially among the elderly. Your RGMs like abscess, fortuitum, and chelone cause more skin and soft tissue infections. With there's high association with chronic lung disease, COPD, bronchiectasis, and cystic fibrosis. HIV, malignancy, transplant recipients, and immunosuppressive therapy are major risk factors for disseminated NTM. NTM more commonly affects individuals more than 50 years of age. Again, as we said, the radiological features, cavity lesions, tree and bud nodules, bronchiectasis, and upper lobe predominance. Extrapulmonary NTM in children is especially present with lymphadenitis, NTM is frequently misdiagnosed as TB in high burden countries. In most of my cases, which came from low resource settings, they were initially thought to be TB, started on ATT. Down the line, they thought it was TB failure, and then when they were referred, they diagnosed it to be NTM. And most of these cases, some of these patients had an earlier episode of TB where cavitary lesions were found, and these NTM went and colonized and infected those cavities. So those sort of cases were also seen. There is some geographical variation. In Europe, species like Kansas more common. Environmental sources or major reservoirs will be mildly touching upon them, why they exist in the environment and in those specific water sources. Incidence of NTM is rising even as TB rates are decreasing. Accurate species identification and antimicrobial susceptibility is of paramount importance. MAC is also the most common species in both pulmonary and extrapulmonary forms in some epidemiological studies. In cystic fibrosis patients, colonization increases with age and lung disease severity. In India, M. abscesses and intracellular, as I just said, are commonly isolated respiratory and extrapulmonary samples. Women are more prone to nodular bronchiectatic NTM, while men often present with cavitary disease. This is the finding again in some studies. Again, molecular identification is important. And with children, we spoke about the lymphadenitis. So again, this is just an image for you to see. I will simplify this image with a few upcoming points. So factors influencing NTM proliferation in water. So here you have host factors like immunocompromised status, underlying lung disease, old age, frequent water exposure. This we know, since we are doctors, we are aware of this. Coming to the environmental factors, that is what I'd like to touch upon. Municipal water supplies, premise plumbing, storage tankers, and distal outlets, these can be sources. Why we'll be seeing soon. The microbial characteristics of the bug, lipid-rich cell wall, chlorine resistance, hydrophobicity, biofilm formation, they are all important components. Transmission pathways, this is very important. This is where the dynamics changes. You have the bug, you have the host. Transmission pathways is a major area of concern, where there's aerosol generating devices like shower heads, faucets, humidifiers, and inhalation of NTM-laden aerosols. The disease risks elevated susceptibility due to convergence of host susceptibility and exposure source. So again, this is a maze which says where all NTM can be cut short, where all in the environment, in the public places, NTM can be cut off and prevented from entering into our hospital. Improved
Nikhil?
water treatment, filtration, alternative dysentery into the system, building up. Yes, am I audible now, ma'am? It got.
Yes, yes. Now you're audible. Yes, Nikhil, please continue.
When you're building a building or a house of water, wherever water stagnation is there can be biofilm formation. Maintain hot water at more than 55 degrees Celsius to minimum dead legs against stagnation. Use copper or silver plumbing. Microbial biofilm control has to be done. Use of efficient filters, more efficient filters of 0.2 micrometer have to be used. UV disinfection can be sought of. And NTM surveillance and monitoring, especially with respect to water sources, have to be done, which is lacking now. So how does NTM survive through these drinking water treatment processes? We all have our drinking water surveillance, where we usually do the most probable number count for coliforms. But for NTM, that shouldn't be the case. You should always, especially when it comes to dialysis water, the AAMI guidelines ask us to do the endotoxin testing to look at critical levels of endotoxin. So how does this NTM survive in water? So it has extreme resistance to chlorine and ozone. Mycobacterium avium requires up to 2,300 times higher your normal E. coli. So this is one. The second important thing is that it can intracellularly survive in amoebae. So there are studies which state that there are some studies coming out of this Stanley Brown lab in Delhi who are associated with the leprosy mission. They say a lot of this NTM go and live inside your amoebae which are there in fresh water. So they are biologically protected. They have prone to form biofilms that we all know, and there is virulence gene activation by disinfectants. You think you are disinfecting the place, but in turn there is virulence gene activation. So exposure to monochloroamine upregulates a specific MCE1 gene in Mycobacterium avium, which enhances entry into human cells. There can also be inactivation, which depends on the physiological stain, sessile or biofilm embedded NTM. That is, there's a biofilm layer, and the lower layer is sessile, which is the inactive or the old layer. The upper layer is the actively proliferating layer. The lower layer is even more difficult to eradicate. Strain specific disinfection variability. There is disinfection variability, different strains. Environmental conditions affect the concentration time. So other environmental factors are also there. Increase in viable NTM post ozone exposure. So again, this can be counterproductive disinfection outcome. Laboratory simulations are difficult. We need full scale simulation of NTM inactivation. You need to know that NTM in this water is completely inactivated and destroyed. That we don't have. This absence of regulatory monitoring. We don't have a proper system in place where NTM in water is properly detected and where surveillance happens. So again, this is a graph which says what are the NTM species present in municipal sources and well. This study comes out of USA and Europe, where you have Mycobacterium gordonii, Mycobacterium avium complex. All these NTMs are found in their water sources. So the why behind NTM in water. So example, if the source is a peat-rich soil or drainage water, that those places are mostly acidic, nutrient-rich, moist. It's ideal for NTM growth. Swamps, soil, streams, rivers, ponds, and lakes. Here the water is stagnant. There is low oxygen tension. There was slow growing NTM. In drinking water systems, there is chlorine resistance. As we saw, chlorine doesn't kill NTM, or it requires massive amounts to get killed. And this helps in biofilm formation and persistence. In plumbing systems, there are stagnant zones, deadlocks, where water can become stagnant, and that can be a place where biofilm formation of these NTMs happen. Devices, water reservoirs, where incomplete disinfection happens. Refrigerator water and other sources. There are some cold tolerant NTM like Mycobacterium abscess which survive in biofilms. Shower aerosols, which we saw earlier. Spa, hot tubs, biofilms. So all these are the reasons why they persist. Coming to our last two slides, where how a specific hospital source can affect and disseminate NTM into our hospital environment. So a hospital tap, water and plumbing. Why NTM thrives here? Because there's biofilm in the pipelines, there's warm stagnant water and chlorine resistance. So this again can cause pulmonary infections, wound colonization and device contamination. Dialysis water systems. There's biofilm formation in the RO membranes, tubings, and improper disinfection. Coming to heater cooler system, especially we've seen case reports of Mycobacterium chimerae, which are present in those water circuits of our cardiopulmonary bypass units. So they can persist and again form biofilms. Flexible scopes are bronchoscopes and endoscopes, which again come to our microbacteriology lab for quality checks for presence of such NTM. So these scopes have complex lumens and can sometimes retain residual water there. So incomplete high-level disinfection again leads to formation of biofilms there. Implanted medical devices. Now, again, this is an important area and a lot of cases are coming up. So introduction via contaminated water or hands or biofilm formation again on these devices. So we have to be careful when a disinfection is taking place for one instrument. It's ideal not to when the disinfection is being happened or incomplete, introduce another instrument into the same water source where disinfection is happening. In low resource settings, to have cost cutting, they follow all these practices which should not be done. So coming to our last thing, is there a genetic epidemiological susceptibility to NTM? Must have heard of the term Mendelian susceptibility to mycobacterial disease. So NTM again being a mycobacterium, there are certain gene mutations which can make a particular patient population susceptible. I've given a few examples here. Your interferon gamma receptor, the IL-12 receptor pathway, which is specific, which is important for Mendelian susceptibility to mycobacterial disease. Then you have the PARK2 pathway. Then you have the NRAMP1 pathway, VDR pathway, SERPINA1 pathway, genome-wide single nucleotide polymorphisms studies have been done. So then again, with respect to cystic fibrosis, you have the CFTR pathway. So all these are examples where a genetic epidemiological component also plays in. So I've come to the end of my presentation. Thank you.
Thank you, Dr. Nikhil, for sharing your insights. Definitely, I mean, It is important to know your epidemiology. If you're going to treat the patients empirically, sometimes we need to take that call. So just like how I was explaining prior, pulmonary NTM, in the study as well, we found that MAC is the most predominant one. So I think we can, in pulmonary in Indian setting, we need to target MAC plus minus abscesses depending upon the scenario. And in extrapulmonary, Mycobacterium abscesses is the thing we need to target. So thank you for bringing that out very beautifully, and your other insights regarding the like how NTM is persisting was very helpful. Thank you, Dr. Nikhil.
Thank you, ma'am.
Next, we move to the next talk, that is lab diagnosis and drug testing in NTM infection. For this, we have Dr. Swapna Nath ma'am. She is additional professor in Division of Microbiology at Regional Cancer Center, Thiruvananthapuram, Kerala. Thank you, ma'am. Thank you for making time for this. Over to you, ma'am.
Okay, thank you, Dr. Akshatha, for giving this opportunity. Shall I share my slides?
Yes, ma'am.
Can you see?
Yes, ma'am. Yes, ma'am. It's visible. Put it. Can you put it in slideshow, ma'am?
Okay, so thank you, Dr. Akshatha, for giving me this opportunity. So in most cases, there will be only a low index of suspicion, clinical suspicion for NTM infections. So it is often the microbiologist who first raises the alert by reporting AFP in the clinical specimens and thereby prompting the further evaluation by the clinicians. So this session will focus mainly on the practical aspects of laboratory diagnosis and how not to miss the NTM diagnosis, especially in a resource-limited settings. So in addition, I will share our experience in diagnosing the NTM infections and also share the susceptibility data of the NTM isolates identified at our institute. And this might provide a valuable insight into the resistance pattern, which is prevalent in our region, and also guide the clinicians to take appropriate therapeutic decisions in the management of NTM infections. So the NTM infections are, as already said, the infections are increasing worldwide and they causes infections in both immunocompromised as well as immunocompetent patients, and sporadic outbreaks of healthcare associated skin and soft tissue infections and also pseudo outbreaks have been described. So they can have a varied presentation depending on the species involved, the site of infection and the host immune status, and they can also cause a pulmonary as well as extrapulmonary diseases. And the disseminated NTM infections can affect nearly all the organs, and depending on the site of infection, the patients may present, if it is a respiratory infection, they present with a chronic cough or weight loss or hemoptysis. If it's a skin infection, they may present with nodules or abscesses or wound infections. If in case of disseminated infections, they may present with fever or hepatosplenomegaly, and in UTI, they may present with unexplained hematuria. Some patients are also being referred to our cancer center because the lesions may mimic the malignancy or metastasis, and they also, these NTM infections can also mimic tuberculosis and fungal infections. So definitive diagnosis is very difficult, and because the patterns will overlap. So the timely diagnosis requires a high index of suspicion, and also it requires a good knowledge of the clinical spectrum and the radiological features. So a specific diagnosis can be achieved only when a granuloma inciting agent, that is the Acinetobacter bacilli, is identified either microscopically or by culture or by molecular methods, but this does not occur in most of the cases. So if it is a deep-seated infection, it is very difficult to get the specimen, and also it requires a lot of time for the diagnosis because of the slow growth. And along with this, a low index of clinical suspicion also result in a delayed diagnosis. So the identification of the NTM species and the direct susceptibility testing and the drug susceptibility testing is necessary for the optimal treatment, because the treatment regimen and the response rates will differ according to the NTM species. So coming to the laboratory diagnosis proper. The laboratory diagnosis requires appropriate sample collection and processing of specimens, and the isolation and identification of the specific NTM species, and also differentiation from the Mycobacterium tuberculosis and other pathogens. So first you have to obtain the appropriate specimen, that is depending on the site of infection, whether it is pulmonary. If it is pulmonary, then you can collect the sputum or the bowel or the lung biopsy specimens or the bronchial wash. And if it's a skin or soft tissue infections, you can collect the aspirates. You can aspirate the samples, or you can take a pus swab, or you can send the biopsy samples or the mesh or other implants if available. And if you are suspecting the bloodstream infections, if the patient has a central line, you can collect the blood from both peripheral and central lines. And if there is no central line, then you can collect two peripheral blood culture samples. And in case of disseminated diseases, you can collect the blood and bone marrow. And in case if you're suspecting lymphadenitis, then you can take the aspirates from the lymph nodes or the biopsy of the lymph nodes. And in case of UTI, you can collect the urine, or you can also do the culture of the stent, which will be taken during surgery, taken out during the surgery. So microscopy often provides the initial clue of an NTM infection. And in the gram stain of the samples, you can see sometimes you can see the gram-positive bacilli, which is very poorly stained. And if you do the acid-fast staining, you can see the acid-fast bacilli, but it is very difficult to differentiate between the Mycobacterium tuberculosis from the NTMs. But the presence of the AFP supports further testing. So it is better to incorporate AFP staining at least for the precious specimens. So this slide shows, I'm sorry, I don't know whether you are able to appreciate it, but this slide shows this is AFP staining, shows the acid-fast bacilli in case of the Mycobacterium tuberculosis, which are actually long and slender and uniformly stained rods, and they are some beaded forms can also be seen. But in case of this NTM, these are actually shorter and also much thicker when compared to the Mycobacterium AFB. And it is may also be pleomorphic and irregularly and faintly stained. And this is a fluorescence staining which shows the bright fluorescence in case of the Mycobacterium tuberculosis, but in NTM it will be an irregular or patchy or less intense fluorescence. So for the differentiation of Mycobacterium tuberculosis and NTM, the samples can be subjected to gene expert or the CBNAT, and if it is positive, then it will be most probably it will be Mycobacterium tuberculosis, and negative, most probably it will be an NTM. Nowadays, multiplex PCR kits are also available, which can simultaneously detect the Mycobacterium tuberculosis from the NTM and NTM from the clinical samples. And gene sequencing can also be done directly from the samples. So the routine culture media such as the blood agar and chocolate agar, which we use in our lab, and also the LJ medium and various liquid cultures like the midget and also the brain heart infusion broth will support the growth of most of the species of NTM. But certain species like Mycobacterium haemophilum and Genevans, etc., might require some special supplements for the recovery on culture. So decontamination may be necessary in case of respiratory samples or other contaminated samples which are contaminated with the normal flora and all. So because the slow growing NTMs may be outcompeted by the faster growing bacteria, and the most commonly used method is an alk-NaOH method for decontamination, but there should be a balance between preserving the mycobacteria and removing the contaminants. And also some rapidly growing mycobacteria like the Mycobacterium abscessus may also be adversely affected by the harsh decontamination. So growth parameters, you can see that there is a very varied temperature preference. So you have to incubate the cultures at both 35 to 37 degrees centigrade and also 28 to 30 degrees centigrade for optimal recovery. And it takes around 1 to 8 weeks for the NTM to grow. If it's a rapid grower, it will take only less than 7 days. If it is intermediately growing mycobacteria, it will take around 7 to 10 days. And if it's a slow grower, it will take more than 7 days. That is approximately 2 to 6 weeks. And the NTM may also produce pigments, and which will also help in the preliminary identification. So from this slide, we can see that both temperature and duration of incubation are very critical for the recovery of NTMs. So species identification is also important, and which can be done, which is currently done using the molecular and also the proteomic methods. So the molecular methods which are available include the PCR assays and the line probe assays and also gene sequencing. And the MALDI-TOF can be done for the rapid identification of the cultured microorganisms. So histopathology provides a supportive evidence of a chronic inflammatory process, and it also helps in the diagnosis of the NTM. So if there is an AFP positive sample, you have to perform the gene expert. And if it is positive for NTB, it is most likely to be tuberculosis. And if it is negative, then you have to proceed with culture and observe the growth rates and colony features. And if whether it's a rapid grower or a slow grower, and you can perform the molecular identification, and also you can confirm the NTM species. You can also do the PCR test directly on the samples. So once you have confirmed the NTM species, you can perform the drug susceptibility testing. And if it is clinically significant, and you can correlate with the clinical and radiological findings before treating. So now coming to the drug susceptibility testing. So the main aim of the drug susceptibility testing is to guide the optimal treatment, because the resistance pattern may vary and it depends on the species and also subspecies which is involved. So the guidelines are given by, for susceptibility testing, are given by the CLSI, and which was updated and expanded in 2011 and 18. So the current guidelines is the CLSI M24 guidelines, which is a third edition, which gives the recommendations for susceptibility testing. So the updated breakpoints and quality control recommendations are now available in the supplementary document, that is the M24S, which was released in 2023. So it gives recommendations for the first line and second line drugs, and the recommended standard susceptibility testing method is the broth microdilution. So these are the drugs which are recommended for the rapidly growing mycobacteria, which includes the macrolides and the aminoglycosides like dimethicillin and tobramycin and quinolones, moxifloxacin and ciprofloxacin, and other drugs like doxycycline, imipenem, linezolid, and cotrimoxazole. And for the slow-growing NTMs, it is the macrolide, the clarithromycin, ethambutol, rifampicin, minocycline, amikacin, linezolid, and the ciprofloxacin and moxifloxacin and cotrimoxazole. So it should be tested. The drug susceptibility testing should be done only on the clinically significant isolates, usually the Mycobacterium avium complexes and also the rapid growers. So the isolates which are obtained from blood, other body fluids, and skin and soft tissue infections are usually considered to be clinically significant. So since this NTM may colonize the respiratory tract, the American Thoracic Society and IDSA have put up certain criteria, which includes at least 2 or 3 NTM positive culture positive sputum, or 1 bronchial wash or lavage sample, or you can take a transbronchial or lung biopsy specimen with supporting mycobacterial histopathology and a positive NTM culture. So the testing also is very tedious, and it requires training and experience, and you have to validate it initially and also at regular intervals to demonstrate the proficiency. And currently there is no dedicated EQUAS facility for NTM testing in India, and the laboratories that perform NTM should also consider comparing their in-house results with an experienced referral lab. And those laboratories who encounter NTM only infrequently should submit their cultures for AST to a reference laboratory with expertise in NTM. So in resource limited settings, the disk diffusion test may be used as a preliminary method for assessing the AST in NTM, although it's a crude approach, and also it lacks standardization, because in our institute also we send the samples to CMC Vellore for susceptibility testing, which takes around 1 month for the report. So in the meantime, if you want to start the treatment, we usually put this diffusion susceptibility testing on the Muller-Hindenburg agar plates. In an 80 millimeter plate, we'll place only one disc, that is of either amikacin, clarithromycin, or imipenem. And if the zone size is more than 50 millimeters, we have found that it correlates with the susceptible breakpoints in the microbroth dilution. So this is a summary of the NTM isolates of the Regional Cancer Center, and you can see that we have isolated around 11 Mycobacterium abscesses, Mycobacterium abscesses isolates during the past 5 years. So this in the bloodstream infections, we have noticed that Mycobacterium abscesses was a common isolate, and two of the patients had central lines. And in UTI also, all these patients had ureteric stents, and the isolate which was obtained in all these cases was Mycobacterium abscesses. And in surgical site infection, one patient had the Mycobacterium abscesses, but it was a multi-drug resistant strain. And in all these patients, those patients who had SSI, usually there were some infected implants or mesh, and the most of the cases presented within 1 month of surgery. While in some cases the infection was noticed around after 4 months of their surgery. Then one patient had an peritoneal presented with the right iliac fossa mass, and from which Mycobacterium abscesses was isolated. In most of the cases of surgical site infections in our institute, the common isolate was the Mycolocibacterium fortuitum, and only in one blood culture sample we got the Mycolocibacterium fortuitum. And one patient presented with multiple abscesses all over the body, and thinking of fungal infection, he was started on antifungals, and but he didn't respond, and finally sternal aspirate was taken, and the FV was grown after 20 days of incubation, and it was identified as Mycobacterium intracellular from CMC velour. And now we have Malditoff in our institute, and now we are able to perform the susceptibility testing, the identification. Earlier it took around, as I told, around 1 month for the identification also. Now the turnaround time has been reduced to around 1 hour after getting adequate growth on the culture plates. So this one actually, it was an outbreak which happened in 2010, where the patients presented with surgical site infections after surgery, and the surgery was performed. There was a gap of around 6 months, and following which the patients developed surgical site infections, and 3 children also developed multiple abscesses all over the body. And it was found that the dye which was used for marking the site of the surgery, that is the methyl violet solution, was contaminated, and it was a source from which the Mycobacterium macillians was isolated, and it was identified from the Rajiv Gandhi Institute of Biotechnology in Trivandrum. So we could identify this outbreak at that time only because we did AFE staining of the aspirates. We used to do AFE staining of all the aspirates, and also later on we recognized that this AFE can be seen in the pus swabs, and all those culture plates which grew no organisms which were sterile after 48 hours were further incubated, and these organisms grew within 3 or 4 days in the culture plates. And the 2 cases of NTM, which all these cases actually we had isolated in around 2012 and 14 and all. And at that time, we were not able to send these isolates for identification. So following laparoscopic surgeries in some other hospitals, also 2 patients developed this NTM infections. And some patients presented with just an abscess of a finger or some breast abscess like that. And in all those cases, we could isolate the NTMs. So this is a susceptibility profile in which you can see that we had sent around 10 isolates of Mycobacterium abscesses to CMC velour, and this was a susceptibility pattern which was obtained. And it was seen that this is the Mycobacterium abscesses which was susceptible to all the strains were susceptible to amikacin till 2023, and after that we had obtained 2 strains which were moderately susceptible, which were only moderately susceptible to amikacin, and 1 strain was almost a completely resistant strain, which is a multi-drug resistant strain. And you can also see that the strains were also somewhat susceptible to clarithromycin and also linezolid. And it is this Mycobacterium abscesses are comparatively drug resistant strains when compared to this Mycolocibacterium fortuitum, which was found to be sensitive to amikacin, moxifloxacin, and also ciprofloxacin, clarithromycin, and imipenem and linezolid. But in this case of Mycobacterial abscesses, you can see that none of the strains were susceptible to moxifloxacin and imipenem. So how not to miss the NTMs? What are the clues in the lab? So there should be a high index of suspicion, and a clinical microbiologist should always have an investigative mindset to explore the definitive causes of infections, especially in cases of patients having persistent, recurrent, and chronic infections. So if you all know that they are slow growing, so do not discard the culture plates in case if there is no growth after 48 hours, you have to incubate it further. And the rapid growers will grow within 3 to 5 days. But if it's a slow grower, it might take a longer time for the growth. So the positive blood culture samples which do not show any organism on gram stain or shows only very slender or faintly stained gram-positive bacilli on a gram stain, you have to do the AFB staining. So usually those bottles are show positive only very late, that is by around the 3rd or 4th day. So if the patient comes with UTI and if the urine wet film shows the pustules and numerous RBCs and again no growth on the culture plates, do the AFB staining of the urine. And if you see the AFB, then you can do the CB-NAT. And if it is positive, then it will be MTB. If it is negative, then it will be most probably NTM. Similar is the case of any pus aspirates or tissues. If it shows numerous pustules without any organism, do the acid-fast staining, inoculate into the blood culture bottles also and keep it for long incubation. And meanwhile, you have to do the CB-NAT also. So beware of the long incubation period of certain NTMs. And these NTM infections may also coexist with other bacterial infections. And it is also a mimicker of malignancy and metastasis and TB and fungal infections. So remember, outbreaks can also occur if non-sterile items are used for the surgery. So the identification of NTM species and drug susceptibility testing is essential for the optimal treatment, and the duration of treatment depends on the clinical and radiological clearance of infection, and the chance of recurrence is high in case of incomplete treatment and also in case of immunosuppression, and above all, a good rapport and communication with the clinicians is highly essential. So the AFB staining provides a rapid and cost-effective approach for the preliminary detection of NTM in clinical samples, and it remains a cornerstone of diagnosis, and without performing AFB staining, the NTM infections are likely to be missed. So thank you, Dr. Akshatha.
Thank you, ma'am. Thank you for making time for being a part of this initiative. Really, I think many times it is the clinical microbiologist who gives us the clue regarding the that it is NTM. So it is the most underdiagnosed. So being vigilant as a clinician and as a clinical microbiologist is equally important for the effective benefit of the patient. Thank you, ma'am, for bringing forward this.
Thank you.
With this, we move to the last but not the least, the talk, is it always NTM? So we have discussed in and out about the NTM, when to suspect. So sometimes we do think it is NTM. So to address this question, we have Dr. Neeta. She is assistant professor in infectious diseases at the in Government Medical College, Thiruvananthapuram. Over to you, Dr. Neeta.
Thank you, Dr. Akshatha. Shall I share my slides?
Yes, Dr. Neeta.
Is it visible?
Yes. Can I put it on slideshow?
Okay. Is it in PowerPoint mode, right?
Yes.
Yeah. Good evening, everyone. So last 1.5 hours, we were talking about NTM. And my topic is regarding, is it always NTM? There has been always a bias when we walk through an NTM working diagnosis, when we have seen a proper case or a multiple number of cases, there is a possibility that a similar case presentation, we may get misled by that and thinking of NTM, and we go for treatment. Maybe we may start an empirical treatment, and maybe what all like how it can get misled also. And there we have in the past number of presentations which we had right now, we have seen the empirical treatments also. So before not going too much into that, let me walk you all through a case. Okay. This is a 38-year-old lady presented with intermittent fever, abdominal pain, and distension for 1 month duration. She had underwent laparoscopic excision of right ovarian cyst 1 month back. So the diagnosis was right ovarian cyst, and 1 month back she had this operation. So post of day 3 onwards, the patient started developing intermittent fever, that was high grade fever spikes with progressive abdominal distension and abdominal pain. So with these findings, she was not in shock also. Her vitals were stable. So let me ask you, what are the differentials you will be thinking in your mind on post-op day 3, fever spikes, progressive abdominal distension, abdominal pain? So yes, these are the differentials. We will be having two sets of differentials, a possible infectious etiologies and non-infectious ones. So in infectious causes, obviously a intra-abdominal abscess with the GI flora only would be the causative organism you will be thinking. The surgical site infection presenting within 48 hours, or 48 hours means she presented with fever on the third day. Peritonitis, secondary to, that's a iatrogenic peritonitis, secondary to a bowel injury during the surgery. And last but not the least, infection with an atypical organism, maybe pot contamination. It is on the third day, it is not impossible, but it can happen. So non-infectious post-operative complication is very common. So post-operative ileus, including early adhesive bowel obstruction, also should be considered. So these were the DDs which they had worked up in the first hospital where the patient was admitted. So these were their DDs at that time. So they were working up through these DDs, through what all abscess, everything they had worked out. So first and foremost, they went for a USG abdomen, which revealed ascites, and hence she was diagnosed to have a complicated intra-abdominal infection, probable a secondary bacterial peritonitis. So seeing in view that she was started on empirically on injection piptas and metronidazole in that hospital, and the ascitic fluid tapping was done, which was suggestive of an exudative peritonitis. So the important thing to note here is that she also was having cheesy-like material discharge from the port, one of the port site. And this was continuously, it was coming, and the material was very cheesy. It was not like, the abdomen was not that tense, like an abdominal obstruction was there. Apart from that, cheesy-like material was coming. So, in spite of giving this much antibiotics, she was not having much of symptomatic improvement. So, the patient attenders took her to another tertiary care center. So, this was the second hospital they were going. So, since the first discharge was from the lab port side, possibility, since last few presentations we are discussing, a port site, there is a possibility of skin and soft tissue infection, everything we have seen in the first presentation cases also. So possibility of an atypical mycobacterial infection was considered in the second hospital, and they went for a CECT abdomen and pelvis, and which was suggestive of multiple peritoneal and subdiaphragmatic nodules along with loculated ascites. So they were having, considering the DDs of some other probability of some malignancy. They sent for tumor markers and everything was negative, including CA19-9. So they repeated the investigation. The pus as well as the ascitic fluid was aspirated and sent for AFB staining, culture, midget culture, fungal staining, and culture. So everything was non-contributory. They didn't get anything from those. As you can see, these are the nodules, the peritoneal nodules in this patient, where the laser is pointing, multiple peritoneal nodules in this patient. And here is the collection, the subdiaphragmatic collection, as well as the splenic collection you can see. So perisplenic collection as well as the subdiaphragmatic collection. So multiple peritoneal nodules and collections were there, which added on to possibly still they were not at any point of finding out what was the etiology. So they considered the probably an NTM infection. And they started the patient on a empirical regimen for NTM, which includes meropenem, linezolid, clarithromycin, and amikacin. Initial regimen was something else, but they finally it was made into this one. The midget culture and the TB PCR, everything came out to be negative. And finally, still the patient was not having much of symptomatic relief, and ongoing pus discharge was there from the port side, and there was persisting pulmonary node, the peritoneal nodules were also there. So they came to our tertiary care center for further opinion, for a second opinion. Now here, let's revise the differentials. So what do you all think regarding the differentials? What is she having? Is it a surgical site infection which we were seeing in the first, when the first hospital saw the patient regarding surgical site infection, intra-abdominal abscess, or maybe something they missed, anything could be. So NTM infection, which was the working diagnosis, could also be considered in this because it was a non-healing. It was continuously, patient is in the same state. NTM infection, they didn't get any kind of documentation for a positive culture or a microscopy. Maybe they were treating and not a proper regimen was followed. So that is why NTM infection is still persisting. Peritoneal carcinomatosis was the second probability because that also was not kind of a self-limiting one. So even though markers were negative, still there was a possibility. Abdominal tuberculosis was another consideration, maybe missed in the initial diagnosis, sometimes enhancing peritoneal nodularities along with gross ascites. We should consider that. Then there is something called a chemical peritonitis, could be a possible differential. So uh, let's work up these with these differentials. These were the differentials we had considered when the patient was referred to us. Now, the devil is in the details. We have to see the patient as a whole. Whenever we come with something like several pointers were there in this case regarding pus cheesy material discharge from the port, patient underwent a surgery, intraoperative procedure, there is a possibility of NTM infection. Those things will be there, which will prompt us to start with an NTM regimen. When we are so desperately trying to find out a microbiological diagnosis, still not getting anything, maybe we will land up in start a treatment of NTM, maybe empirical regimen we will start in most of the cases. Everyone have done that. So in this case also for the first hospital when they had done that, we went through all those case details again and again, and the first hospital biopsy report came out to be the ovarian cyst which they had operated was a mature dermoid cyst. And in the intraoperative notes, they have mentioned there was a spillage of dermoid cyst during the laparoscopic surgery. And their cultures were AFB staining and culture were negative, and PCR was also negative. PCR for the Mycobacterium tuberculosis as well as the NTM. The second hospital continued the treatment as atypical mycobacterial infection was started. They started the treatment, and there also again they did the same aspiration and microbiological workup was done. All results were negative. So reassessing the case details again, what it could be? It could be something which happened because of the primary disease pathology, maybe a spillage of the mature dermoid cyst which caused a chemical peritonitis. That could be gliomatosis peritoni. This is a kind of chemical peritonitis. So which was getting treated with NTM regimen without much of a microbiological diagnosis. The patient had to go through this procedure for more than a month when she landed up to us. So this is another case. This is not a rare condition. There are numerous case reports regarding this. Granulomatous peritonitis secondary to benign cystic ovarian teratoma. This is regarding ruptured surgery. So this is also a lady, that 34-year-old middle-aged lady. History of laparoscopic dermoid cystectomy was done. There was spillage during the time of surgery. They presented with right basal pneumonia, and the CT was showing deposits within the right subdiaphragmatic space. Okay. there was subdiaphragmatic space. There was collection. There was deposits. And repeat laparoscopy was also reassuring because it is a self-limiting condition. There are, as you all know, the dermoids are mature and immature dermoids are there. And most of the cases, the mature dermoid, if it accidentally spills also, the chemical peritonitis, which in only 2 to 4% of cases there will be a spill. So there will, during the extraction, during laparoscopic procedure, and when it happens, it is a kind of self-limiting condition unless we have to go for steroids. So the patient will, the course of the disease will resolve on its own. So the repeat laparoscopy was also reassuring, and the biopsy of the peritoneum showed the inflammatory infiltrate, numerous macrophages with multinucleate cells, some of which appeared to be amorphous, and fragments of hair was found, which was conclusive of the spillage of, which is conclusive of gliomatosis peritonei. So as I have already mentioned, the benign condition and the dermoid, which is have a very thick capsule, very rare, or maybe 1 in 4% cases has a risk of spillage, which can cause a chemical peritonitis. The features are very similar to that of any kind of granulomatous lesion if it doesn't show any hair or anything in the biopsy. A granulomatous lesion, patient is having abdominal distension and an intra-abdominal procedure was done. So everything will fit into that, and there is a possibility of misleading the clinician. And even if there is no fat, there is any absence of fat, there is a possibility of getting confused with a cancer, ovarian cancer also. So it can mimic malignancies also. So on so macroscopic fat could, absence of it could simulate an ovarian carcinoma. CT is the one which will give a pointer towards the diagnosis, and along with CT and MRI, biopsy or the frozen section of the peritoneal implants should be considered for getting an accurate diagnosis and to avoid irrational use of antibiotics. So when a dermoid structures, what are the confounders here to think of it as NTM? When a dermoid structures, it's condensed like sebum, hair, everything can spill. And not only ruptures, when there is accidental leakage also, which happened in this case, there can be chemical peritonitis. And this body's immune system will try to compose it with the inflammation, forming granulomas. And these granulomas and the overall inflammatory response are difficult to distinguish from those of NTM infection. Clinical presentation also will mimic like that. So this is a article present in the published in the International Journal of Obstetrics and Gynecology, and removing a dermoid cyst from granulomatous, how can they prevent? So they have found that in 314 patients, when they are doing laparoscopic removal, an endoscopic retrieval bag was, when it was tried, they could reduce the amount of spillage and chemical peritonitis. So this was published there. So this is a common topic, and physicians are more aware of this condition rather than the physician and ID physician. So so we should be more knowing about everything in and out regarding the mimics of infectious disease, including the commonest one which we are dealing with. So coming to the learning points, while a ruptured dermoid cyst can be a distinct clinical entity, its inflammatory response and image findings can overlap with those of NTM infections, leading to potential misdiagnosis. And this misdiagnosis can lead to unnecessary use of antibiotics for a prolonged period of time, like maybe more than 6 months to 1 year, as we have seen in the treatment regimens of NTM. And we won't be getting any culture positivity as well as the den or anything will be there in between if we have already started the patient on empirical treatment. The accidental spillage of mature ovarian teratoma, which is uncommon, lead to chemical peritonitis, where the rupture of immature teratoma is more or less a clinical presentation of a peritoneal carcinomatosis. Mature, we have already discussed. Immature one will look like patient will be having more pronounced symptoms, and the emergency surgery is the indication, is the treatment for emergency surgery is a treatment of choice. And the self-limiting nature of the disease process in mature teratoma spillage is carefully assessed and monitored for the proper treatment. A proper radiological study combined with histopathological examination in suspicious cases is critical in reaching the diagnosis, and this is crucial, which can avoid misdiagnosis of the infectious etiology, especially non-tuberculous mycobacterial infection. So with that, I would like to stop my presentation. And in this case, the outcome was that by the time we could identify it as uh, not an NTM infection, she got resolved of all her clinical symptoms, and she is fine. So I would like to extend my thanks to our HOD, Arvind sir, Department of Infectious Disease, and Kiran sir, Associate Professor, and my colleague Dr. Anish for all the help and support for preparing this PPT. Thank you.
Thank you, Dr. Neeta. Yes, it is. It was truly thoughtful, and definitely, I think we would have definitely considered and treated for NTM, and unnecessarily the patient would have been on so long. Again, I feel as an ID physician, our job is to play detective and to look at all the reports. Thank you for bringing this out so beautifully.
Thank you. All the sessions were very nice in hearing. It was a kind of eye opener in case of our everything regarding the first talk. So many cases we discussed, as well as ma'am's presentation regarding the NTM antibiogram, which will help us in finding out more rational regimens and the epidemiological pattern of nickel stock also, and the case presentation Dr. Teja is having. Everything was very nice. Thanks, Dr. Akshatha.
Thank you. So, with that, we wrap up today's CME on NTM infection. A big thank you for all the expert speakers for their time and clarity and their insights. And to the audience, thank you for your enthusiasm and participation. So, if you enjoyed this, you will find more content on my YouTube channel, Learn with Dr. Akshatha. So, where I discuss a lot of case-based ID learning. So, let's keep learning and sharing and growing. Uh, with that, happy World NTM Awareness Day to all once again. Bye. Have a great evening. Good night.
Bye.